we've learned an awful lot from pathology in terms of trying to determine how we approach, and that feeds into this. But the artery starts out life open, and often it blocks. Sorry, that's jumped. So often it blocks here, and as time goes on, it moves proximal. So whenever you see a blunt cap, that tells you it's been there a long time. Whereas when you see a tapered cap, that tells you it has not been there a long time. So the case we just did had a tapered cap. So that tells me, in terms of pathology, it is not a very old CTO.
What does old mean? What does recent mean in terms of it?
So it's actually much easier to define it in pathology terms rather than angiographic. And often, as you know, there's uncertainty as to the duration. If you see a tapered cap, so if you remember, the JSC2 score gives 1 point for blunt and 1 for tapered. What they're actually saying is, if you've got a tapered cap, it isn't a very old CTO. Now, I can't tell you how many weeks, how many months, but it's not years. And that is favourable for antegrade wire escalation. Once you see a blunt cap like Jono had, especially coming off at a side branch, it is not going to be suitable for wire escalation. Okay? So whenever people say, I always start with a Fielder XT, fine. But if you've got a blunt cap and a large branch, the pathology tells us it's going to be tough. It's been there a long time. Your Fielder is not likely to go through the cap. And what I was trying to say earlier, who in the room does predominantly wire escalation? Who's on radical dissection around? Who's on radical cases in the room? Radical dissection rendering? So most people are trying to wire. Now, let's say, for example, you have a scenario like this, and you're trying to get wiring in. You're not familiar with dissection techniques, so you do not want your equipment subintimal beyond the distal cap. In theory, you are trying to wire down here. Okay? The further you wire here, the harder it is to get wired into here. So let's say, for example, you take a CP12 here. It's stiff, it will puncture through, and you're starting in a good position. Let's say, for example, you take a Fielder XT. Will it penetrate through? No. What will it do?
Deflect on the side.
It will deflect the side, and what else will it do? It will buckle. And what do we call that? A knuckle. So if you take a guy 1 or a guy 2 or a Fielder, you are more likely to end up in the wrong place. And given that you don't have the skill set to take a stimuli like John did in the enter, you want to avoid that. Okay? So I think when people say, I always take a Fielder, that makes no sense to me, because you are potentially ruining your chances of wiring. Whereas if you take a CP12 based on the anatomy, you're in a much better position to control the case. Does that make sense?
Does the presence of calcium, can you use that as a guide if you want to penetrate?
What we know is, that, again, the JSC2 score, so the more calcium you have, the more tortuosity you have, the longer, the less likely you are to wire it. And I've got that in a graphic form. So these techniques are not for JSC2 score 0 and 1. Just wire those. Everybody wires those. You saw, where's Sam? You saw a case where we wired a 30mm occlusion, but it was a tapered cap, so we knew from the anatomy that it was going to be favourable for intimal wiring.
Regarding this diagram which we have got, is CP12 just to puncture through the proximal vigorous cap and then we de-escalate, or
Correct.
keep on going
Correct.
to CP12?
Correct. You can't always uncertainty. You want this through the cap, and then you want to bring in your microcatheter and de-escalate. And then the wire that you select for the next part is based on the anatomical features. Let's actually go back to the other talk, actually. There's a lot of overlap on this, but I'm going to go through it. Wire-based strategies are for simple anatomy. Complex anatomy, wire-based strategies do not work. And these are our data where as the complexity goes up, so as the JC2 score goes up, the chances of you wiring it go down. So if you've got a calcified lesion, if you've got tortuosity, a blunt cap, and it's long, I'm not telling you not to try and wire it, but don't spend very long trying to wire it, and be careful where you go with your equipment, because you're more likely to perforate with wire escalation in this scenario, and dissection techniques are much safer. And what we are trying to teach is safely, so we don't do a talk on complication management, we talk about complication prevention.
When you use CP12, you always use it with a microcatheter, or you can use it without?
So again, I hate saying always, but why would you not use a microcatheter?
Because if you use microcatheter with your guy too, obviously that also sometimes adds to the support.
Yep. Well, why, if you're doing a CTO, why would you not choose to use a microcatheter? Is there any advantage of not using a microcatheter apart from cost? No. Unless, say, for example, you get halfway through here, you find an area that you have to change your wire. You don't have a microcatheter, so you have to give up your position. So people do things that take shortcuts, you're trying to save money, you're doing it for the right reason, but it costs you money in the long term, and it costs you the chance of success.
Ideally, how far should be the tip of the from the tip of the microcatheter?
Not any more than 5-10 millimeters. Not anymore. Too dangerous. So this is your anatomy. Once I see this tells me it is going to be tough. Whereas once I see this, it is going to be, and we see this from pathology, where you start with thrombus formation. Over time, this becomes organized, and the vessel changes. And you see this in terms of pathology. So a fresh CTO, if you look at it in terms of pathology, has got thrombus, it has got channels down through it, and as it organizes, this you could still wire down through tissue planes. But once you get to this at the far end, which is a long duration CTO, how is that different from that? Are there microchannels over here? No. Is the vessel larger or smaller? Smaller. Is it calcified? And it's negatively remodeled. So the chances of you wiring down through this with a Gaia third or with a CP12 is very, 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 very low, but is also extremely dangerous. If you've got this sort of setup, any wire will go down through that, whether it's a fielder, a fighter, Gaia family, Pilot 200, because this is where your wires are designed to work. Okay? And what we're trying to get you to think about is make a decision based on the anatomy and what is the safest thing for the patient. We've shown that the techniques are safe. We've shown that they're durable. So if you're making a decision about which strategy to take, the first thing it should be the patient safety. That should be the first thing. What is the safest procedure for this patient? Okay. So, and again, if you look at the pathology of a tapered cap and you follow it from distal to proximal, you will see that there's a lead-in. You're going to start in the right position, and the chances of wiring down through this is extremely high. And the success rate of a JC2 score 0 and 1 is practically the same as a non-CTO case. Well, back to, there's too many questions on wire escalation, John, so I'll move back. Whereas once you see this blunt cap, especially at a branch, this was a scenario Jono had, small branch coming back to large vessel, you do not have something that you're going to wire down through. So we're not saying don't do it, but don't spend very long doing it and have a very low threshold for moving towards dissection. Who's familiar with virtual histology? So you can do virtual histology, which correlates very, very, very well with pathology. And this is a case report of a tapered cap, long CTO, but whenever you do the virtual histology is identical to what you would see with an acute coronary syndrome. And it is thrombus which is becoming organised. So this is a short duration CTO, tapered cap. It is almost identical to acute coronary syndrome pathology because that's how it develops in the most people. And the vessel occludes here, and then it goes proximal over time and distal over time. But once you see a blunt cap in a proximal right coronary artery and a blunt distal cap at the crux, you can be convinced that that's a long duration CTO. It's going to be fibrotic, calcified, the vessel is going to be small, and the chance of you wiring it is going to be less than 10%. So don't start on it. Okay. Does that make sense? And then in terms of the wire, there's a lot of duplication, categorization. I'll maybe switch back to the other talk at this stage. Wires are confusing. Who can remember this table? Now, can anybody in this room tell me the difference between a Feeler XTA and an XTR if I put them to you blindly? Could you tell me the difference? No, you really couldn't. 0.2, 0.4 gram of a tip load difference. Can you really tell that in an artery with a microcatheter? No. Now, can you tell the difference between a CP12 and a Feeler? For sure. Can you tell the difference between a CP12 and a Pilot 200? For sure. So what we do is we categorize wires into low tip load, medium tip load, high tip load. And after that, it's up to you to sub-select which wire you want with a high tip load, which you want with a low tip load. But don't try and tell me there's a difference between a Feeler XTA and XTR and a fighter. There's not really. They all have very, very, very similar properties within that bracket. Microcatheter we've done. Properties of the wire. So the anatomy determines what type of wire you should choose. So if you've got a tapered vessel, we think there might be microchannels through. So what properties do you want? Do you want high or low tip load? Low. You might want medium tip load, but you certainly don't want high. Do you want a tapered tip? Yep. Do you want a jacket? Yep. So what's that wire called?
Feeler XT.
Feeler XT, fighter. Okay? But those are the properties you're looking for. So describe the properties you want and then work from there. And then in terms of medium tip load, there's two considerations. Do you want a jacket or do you want torque control? Okay? So when might you want a jacketed medium tip load wire? What sort of scenario?
Microchannels.
Pardon?
Microchannels.
Microchannels is going to be low tip load. Okay? So we're talking about medium tip load. We're talking about Pilot 200, talking about Gladius, we're talking about Gaia. Calcification, tortuosity, you want a jacketed wire. Okay, so we'll go through this. This is just wiring. If you've got a blunt proximal cap, do you want high penetration? Yes. Do you want a tapered tip?
Yes.
Why is that?
Gives you more force.
More force. So if I'm wearing stilettos, I'll do more damage to this floor in stilettos than I will in my current feet. They're very nice stilettos. Do you want a jacket? Do you want a stiff penetration wire with a jacket?
Not necessarily.
So this is binary. Who wants a jacket? What's a jacket going to do? Slip, no control. Do you want no control in this wire?
You want precise control.
Correct. So what you don't want a jacket, and you want as much tip control and feedback as you can. So no jacket. Okay. And it's, you know, you're all talking relative when you talk about the feedback from a CP12 or a Hornet 14. There's not a lot of feedback, but there's a whole lot more than if you're using, say, a Gaia. So these wires are designed to penetrate through, and then once you get through the cap, you change. You saw an example, Jono showed the example of the IVUS identifying where the proximal cap was, and a really lovely example. That we've moved on from, in that the IVUS doesn't help you get across the cap. So let's say, for example, you've got a side branch here. Is anybody going to lose any sleep about losing that side branch? No. But it's a great anchor, isn't it? So you have anchor options, you put a wire in here, you use dual lumen catheters. This side branch now offers us a lot of opportunity to get into the main vessel. Okay? So these small branches are functionally irrelevant. We don't worry about them. Now, these big branches we do worry about. Okay, the circumflex is usually a relevant branch. So you have to be careful. So you'll take different approaches depending on how important the side branch is. And we try very hard not to lose side branches that are important. You know, we'll be very, very clear on that. This is the IVUS, where you've got the small vessel with no disease, and then about 12 o'clock you see this subtle appearance appearing as you come from distal to proximal. Okay, there you can see the wire. Now the real-time IVUS doesn't actually help you. It can show you where the wire is, but it can't show you where the tip of the wire is. So in this case, coming from the vessel back, you can see the wire is in the vessel, and on the angiogram, that, you know, it's helped us, but this does not actually help you get through the cap. Okay. Well, we've got, so let's move on from that one. This just shows what we were saying earlier, that as the complexity increases, the chance of wire escalation decreases, and the need for dissection techniques increase. So in terms of dealing with the proximal cap, you can increase the power, you can modify it, or you can ignore it. Thank Jono for the graphics. Did you draw these yourself?
Yeah.
Most people know if a wire goes through the cap, how to deal with it. You know, wire, microcatheter. What we want you to think about is, if that doesn't work, what is your next strategy? So, wire won't go. Change the microcatheter. Use an anchor balloon. This is what Hussein and I did, where we used a parallel anchor. So we brought the microcatheter down to the cap. We put a balloon up parallel, and that fixed the microcatheter. It also stabilized the guide. And we would do this very, very commonly. And that allowed us to attack the cap with a lot more control, guide cath extension, and the use of dual lumen catheter. So these are all strategies that you can use if you cannot get through the proximal cap. Okay? So you've got your specialty microcatheters, Turnpike Gold, Tornus, they're in the same category. You can use anchoring techniques, side branch, coaxial, guide cath extension, and dual lumen catheters. We're using a lot more dual lumen catheters. So if you look at the bottom, you're trying to get your wire to go towards 12 o'clock, but you're pushing towards 9 o'clock. If you take a dual lumen catheter, it will stabilize the wire and it will increase your support in this direction. The same with the Stingray. So if you're trying to re-enter up here with a microcatheter and a CP12, it's very difficult. Whereas if you've got a Stingray, it is much more predictable. And this little graphic shows what happens with a proximal cap. And it's amazing how much your microcatheter moves, not just back and forward, but up and down. As you push on the cap, it backs the microcatheter and you lose your coaxial support. By putting a wire into the branch and using the port of the dual lumen, most people try and orientate this port towards the cap, but it actually doesn't matter. That's not the benefit of the dual lumen. The dual lumen is about stabilising the microcatheter. Look how stable it is. It's not moving forward and back, and it's not moving up and down. And the same wire will now go through this proximal cap very easily. Okay. So the use of dual lumen catheters for getting through the proximal cap is key, and you saw that in the first case. And there's actually data of the increased penetration force with the dual lumen catheter versus an ordinary microcatheter. You know, you can put a heavyweight wire down into a branch, put down a dual lumen catheter, it's not going to move. So all your force is going to be in the direction you want to go. Okay, so dual lumen catheter, you know how to do that. So this is a case example where you've got a nice orientation. So you can imagine if you get the dual lumen catheter here, it's going to line up with this proximal cap down to the distal vessel. Okay, so pretty vertical. Bringing in the dual lumen catheter. So you bring in your dual lumen catheter. In this case, this is probably a twin pass. Okay, so it's engaging the cap on the same setup as before. The wire is now moving. Now, because this is quite short, because this is quite vertical, this is a CP12, you might just let it go on into the distal vessel. If you have any concerns, drop the equipment out, bring in your microcatheter and de-escalate to a medium tip load wire. If you're looking good torque control and you know where you're going, that's Gaia. If you're unsure where you're going, there's tortuosity, there's calcification, then it's a Pilot 200. So any questions on the use of dual lumen microcatheters?
The CP is pre-shaped or U-shaped price?
Shape yourself. The only pre-shaped wires you will use are Gaia and Stingray. The rest of them you shape them yourself.
There is a slight confusion regarding from where this side branch wire exits, from the tip or from the before that?
In the dual lumen.
Yep.
So the first marker is on the monorail segment. The second marker is where your wire is going to exit. But you got to know where that is because each vendor, so this is a twin pass and you can see there's a different length between the tip and that marker than say with a Sasuke. So you just got to learn each particular microcatheter. But that's the monorail end port, and then that's where your wire's coming out.
So with OTW, we break the wire function, the cap.
Yes. It's the one that you've got control over. You're bringing it in and out on the over wire. Modify. A Carlino is a contrast injection which is underutilized. So once you've decided that you're going to dissect, you're not trying to wire, you're not trying to worry about where you start in the vessel, you just want to get started. This is a contrast injection, which is called a Carlino. So this is a 2 ml syringe, neat contrast. And what do you notice? What can you see after the injection? Stain. And it's highlighted the vessel. So a lot of people might look in this room and say, that looks ugly. Whereas Hussam and Jono look at that and say, that looks beautiful. Because you now know where the cap is, you know where the vessel is, you've outlined it. And if you're doing, for example, a retrograde case, you now know exactly where you're trying to go. So once we have committed to dissection, we will then do whatever we need to do to disrupt the vessel to get the case done safely. And then the next stage is, so we've tried to go through the cap by increasing force, that doesn't work. We've tried to modify it. Then what we're going to do, we're going to come proximal. So let's say, for example, we've got a side branch we're not worried about, or there's no side branch. Rather than trying to go through the cap, we go around it. And remember from the pathology, we've said that the cap is the toughest part of the CTO. It's fibrotic, it's calcified. And you'll hear terminologies, base, side base, scratch and go. So scratch and go is where you, rather than trying to go through the cap, you scratch proximal and get subintimal and dissect around it. This is quite hard to do in reality because there's not very much feedback from a CP12. We'll do this manoeuvre much more frequently where we put a balloon up proximal, cause disruption, bring in your microcatheter, and then use a knuckle wire to get into this dissection and get round the cap. Okay. So this is an example. We've got a cap here, we've got our microcatheter, balloon, and what you do is you inflate the balloon, cause disruption. You then bring in your microcatheter, inflate the balloon, and push on. And this knuckle, whereas previously we couldn't get through a cap, has come right around it. So there's a retrograde wire here. So we've caused disruption. You then bring in your knuckle wire, and you've gone around the cap.
Colm, I found this is a very, very useful thing to learn and do when you have very difficult proximal cap. And actually, this is quite, I think when you, as you go on, it's quite reproducible doing that scratching and go. You balloon it, you disrupt it, one-to-one, dissect it, and do the numbers. It's very, very useful.
Just make sure you use a big enough balloon.
Correct.
It's also a bit lazy.
Yeah.
You can't be bothered to go through the cap and just go around it. Don't even try in the first place.
Well, that setup that we had, Sam, that's nearly almost every case we do with a proximal vessel. You know, you put a wire down to stabilise your guide with the balloon, which is either going to fix your microcatheter to let you get through the cap, or if that doesn't work, you're going to cause disruption and dissect. So we almost always will have a wire and a balloon alongside your microcatheter. You know, if it's a difficult CTO, we'll just do that almost automatically. So this is a case that was done in Japan, and you're sort of wondering what's going on here, but the leam is onto the LED, and then there's a critical lesion of this diagonal, which is a large system on MPI, big defect. But whenever you look at it from above, blunt cap, uncertain course, tortuosity. So what's the chance of you wiring down through this, getting into that diagonal, getting into the distal diagonal? Practically zero. And the way this was done was, so there's with a guide cath extension, a course there, and a stat 020, so we've worked right our way through this algorithm to get through a proximal cap, got nowhere, got absolutely nowhere. Then switched to, where are we? Yeah, so I've missed one there. We then switched to using, then switched to a balloon knuckle wire, and watch what happens. Then the knuckle wire overcomes the uncertainty and goes into the diagonal. Bring in a stingray balloon. So here's the stingray, the vessel is lying above it, and do re-entry. And you can't do these sort of cases unless you're using these techniques. So in terms of visual form, what we did was we put a balloon up in the side branch. So this does one of two things. Number one, it protects the side branch so you're not going to lose it. Number two, it increases the penetration force for getting through this cap. Okay. So this is an example. LED uncertainty, many branches. Putting a balloon up in one of the branches, inflating the balloon, and then pushing the knuckle. And as long as this knuckle is bigger than the branches, it will not go into any of the branches, and it will go on down the LED. But look at the angulation that this knuckle has taken. you're not going to be able to commit to that angulation with a wire. It's just going to be too much uncertainty. But by putting a balloon up in the side branch, using a knuckle wire, this allows you to get down into it. Okay, so you've seen this type of setup before with a branch, blunt cap. This would be set up for a dual lumen microcatheter. The other solution is put a wire into the side branch, inflate a balloon. So remember, that's protecting the side branch. And then we come down with a knuckle, push on the knuckle, which will dissect past the branch. Okay? And that is very easy to teach, and it's very easy to perform. Now, of course, you need the skill set to get out of the dissection plane. You know this wire is subintimal when you see a big knuckle like that. The knuckle also tells you how large the vessel is. If you've got a 2mm knuckle, the vessel is 2 millimeters. If you've got a 4mm knuckle, the vessel is 4 millimeters. You're then able to bring in Stingray, crossbar Stingray, and complete the case. And you can see the branch remains intact. So these techniques, we try very hard not to lose side branches. If you're going to lose side branches, you have to do it by a different mechanism. So I'll leave you again with a shameless plug. A lot of this stuff is in the Antegrade iBook. And any questions on that? Stunned into silence.
So how often are you using rotational atherectomy around? Now that you do lots of base and side base, do you still need to do rotor?
No, we've done. So the talk I have on this from even 3 years ago had a couple of steps where you would deliberately rupture a balloon. We call that granuloplasty or balloon-assisted modification. We don't talk about that anymore because we do base and side base. And the other thing we did was rotablation, where you would close your ears, you would cut the really opaque part of the rotor wire, leave 3 millimeters, get it through the cap, and then rotablate the cap. And we call that subintimal rotablation. I have done that twice I can think of in the last 3 years, and probably a similar number yourself. We used to do that a lot because we were trying to go through the cap. Now we've realised that the cap is often the most hostile anatomy, and it's much better going around it. I'm sure you've been in a case where you get a fielder XTA down through a CTO in 2 minutes, and then you spend an hour trying to get equipment through. And that's because you're going down through the toughest part of the CTO.
I think you should learn base and side base at an earlier stage.
I totally agree, because this is it's teachable, it's safe actually,
Yeah.
and it's easy to teach and learn actually.
So as people are learning knuckling for the first time, I think part of that, we should integrate that with base and side base rather than saving it for
That's
later.
right.
And the other thing you will have noticed, which would probably be a change from 5 years ago, both cases we started Antegrade. Even though we were doing a retrograde bailout, and you were doing a retrograde bailout, though you obviously you could play with ADR, but we started Antegrade. Whereas 5 years ago we spent all our time trying to get retrograde and then thinking, aren't we wonderful, we've got retrograde. The proximal cap is often the most difficult part of the CTO. And if you've got equipment retrograde and you can't solve the proximal cap, you can't complete it. So now actually we'll invest a lot of our time in the proximal cap, get the proximal cap sorted, understand the anatomy, get guide cath extension down to a landing zone, and then either ADR or RDR.
And the other thing about the base and side base, just make sure, especially base, make sure that you're not going to compromise and knock off a major branch. That's one of the things that you think into the base. And the antegrade versus retrograde as well. The case that we did together, last young man, he does have CTO circ, CTO right, and LAD disease. So we were a little bit even concerned going retrograde because it's just going to increase his burden of ischemia. So the retrograde associated with more issues with it, associated with it. So, and most of the time when the case becomes complex anyway, you have to have antegrade work done to start with. So I tend to stick as much as I can to antegrade and then use a retrograde.
So this guy had an EF at 25. He's a block right, he's got a block cert, he's got LAD disease. I have no doubt in my mind in America he would have LV support, maybe some parts of Europe he would have LV support, which if you're going to do it all in one sitting is not a bad idea, you know, don't get me wrong, but we were thinking if we can do the right antegrade or as much of that preparation antegrade, then we're not going to compromise, we don't need LV support.
Which is your preferred technique for this proximal ambiguous cap? Antegrade dissection and re-entry, or starting with the bacterocatheter CP12?
It all comes back to you have to look at each individual case, and you have to look at the anatomy, and you have to make a call on the anatomy. What is the most likely thing to be successful? We're not telling you always do this, you always do that. You know, you have to look at each individual case and make a call. What we will tell you is that you got to assess what is the most risky thing for the patient. So for example, an epicardial collateral has quite a penalty with it versus say a septal collateral. So you got to make a call in each case.